Hey guys, so the last thing I'm here to talk about is the OPG review. Now, the OPG can look a bit daunting because there's a lot of structures involved, but no need to worry. The principles are the same, just as an intraoral exam photo. Describe, find significant findings, and then from there, create a differential diagnosis, and from there, find a definitive diagnosis. So, the OPG is used for a lot of reasons. Could be used to assess the TMJ, could be used to assess the any uninterrupted teeth location, could be used to assess impactions, and a lot more. Um, the method that most people use in describing OPG is the right to left, outside in method. It might seem a little bit complicated, but I'll walk you through it. So, my starting point is usually the condyles or TMJ, and then I usually start right TMJ, then left TMJ. So, with the TMJ, I really talk about is the relationship of the condyle head or condylar head in relation to the articular eminence and the articular fossa, and where that condyle is. So sometimes the condyle of the patient will be in the articular fossa where it should be, or it may be uh, just before the eminence and out of the fossa as well. So it's quite important to look at those areas. Now, the reason why it's important is because if it's out of the fossa and not in the articular eminence, on the articular eminence, then that could be implication of a possible TMJ pathology. And TMJ pathology is part of the branches of TMD, and TMD is one of the branches of orofacial pain. So, as you can see, uh, assessing the TMJs is quite important. So once you describe that the relationship of the condyle to the articular eminence, articular fossa, and also just describing the condylar head itself, whether it appears at a normal size, whether it appears degraded, etc. You could then begin to talk about you can move more inwards and begin to talk about large radiolucencies. Now, these large radius usually cover usually the body of the angle of the mandible, or it appears as a radiolucent line covering the ramus of both sides, and then going just inferior to the hard palate. Now, both of those are the oropharynx and the glossopharyngeal airspace, respectively. Now, you can usually find, if you just type in OPG landmarks, usually you can find labeled diagrams with these radiolucent lines already marked. But it's good to describe so that if a demonstrator or assessor or even a patient even asks, hey, what's that area and what's its implication? So next, you can begin talking about the ramus itself. Now, this is important because some patients might have asymmetry, or um, but not in the vertical fashion, more in the horizontal fashion, in the sense that their left side of the face may be smaller to the right hand side face, and that might be due to the ramus of the left hand side being smaller in height in comparison to the right hand side. So it's important to assess the height of the ramus and also the angle of the mandible as well. Um, Once that's done, you can then begin starting to talk about the teeth itself. Now, the way people describe the teeth, it's different in all areas. Some people like to talk about each tooth, like, okay, there is the 1, 4, 1, 3, 2, 3 present. 1, 3 has a amalgam restoration, etc., etc., etc. But just remember, when you're in a case presentation, you don't really have that time to just talk about every tooth. So it might be best to just put up a table and use the significant and to just talk about the significant findings, like, for example, root canal filled teeth, because or maybe teeth with caries with it, um, etc. Um, then once that's done, you can then begin to talk about the actual alveolar bone height. The alveolar bone height is quite important. It's actually one of the reasons why we take OPGs is to assess the alveolar crestal bone height and whether it's within normal limits and whether there is periodontal disease. So and the description is quite explanatory. As I said before, it really is just either the alveolar height of the maxillary teeth appears to be within normal limits or generalized, something like that. Now, uh, then once that's done, you can then move on to actually the edentulous spaces. Some patients have edentulous spaces, and you can then begin to talk. And the edentulous spaces might be a bit irregular. They might have localized bone destruction. There might be something like a root fragment left in, like our OPG here that I've posted up here, and you can use that to describe, and that's important as well because that might have a post-infection and could be leading to pain if the patient is stating that they have pain. So once that's done, that's really it. Just remember always to find why the OPG was taken. That is quite important as well. Yeah, that's about it with OPG review. Um, if you have any questions, again, ask me or ask Dr. Polonawita. And one last tip is just that for not just for case presentations, but for vivas and clinical exams, definitely know your OPG landmarks. It's quite important that you always will question you about what's this, what's that, etc., etc. So really know your OPG landmarks. Not being too detailed. Again, just if you just type up OPG landmarks on Google and kind of familiarize yourself with that, you'll be fine. All right, thank you.